Presented by Dr. Nitish Bikram Deo, who is a MS Orthopedics from Jipmar Pondicherry and is a gold medalist in the MS examination. And at present, Dr. Nitish is assistant professor in pediatric orthopedic and hand surgery unit at Tribhuvan University Teaching Hospital Institute of Medicine at Kathmandu, Nepal. He has finished his fellowship in pediatric orthopedics at Rainbow Children Hospital and Chacha Nehru Bal Chikitsalayah at New Delhi. And he was also Pediatric Orthopedic Society of India Professor K. Wilkins Inland Traveling Fellow, visiting Wadia Hospital in Mumbai and Ganga Hospital in Coimbatore. Dr. Nitish has 6 publications to his credit and is a member of Pediatric Orthopedic Society of India, Nepal Orthopedic Association, and Pondicherry Orthopedic Association. Welcome, Dr. Nitish, and thank you for joining today here in this session to present a pediatric orthopedic case. And to moderate, we have, Dr. Ankit Khurana, who is MBBS from Maulana Azad Medical College and MS Ortho from PGI Chandigarh. And he has done his Diploma of National Board and MRCS Glasgow and FRCS in Trauma and Orthopedics. He's at present Assistant Professor in Orthopedics at Dr. BSA Medical College and Hospital Rohini. He has over 40 indexed publications and numerous national and international presentations at various conferences. Welcome, Dr. Ankit, to this episode of Controversy and Consensus, and thank you for joining to moderate this case.
Thank you, sir.
Now I have stopped. I have stopped sharing the screen, and over to you, Dr. Nitish, to share your screen and present the case.
Thank you very much, sir, for this kind introduction. Sorry, is my presentation visible?
Yeah.
Okay. So, good evening, everyone. So, I'll be presenting on ankle valgus deformity correction, which is secondary to isolated congenital pseudoarthrosis of the fibula with neurofibromatosis 1. So, I'm currently based in Kathmandu, Nepal. I'm assistant professor in pediatric orthopedics and hand surgery unit. So before moving to the case proper, I'm just introduce the case. So unlike the congenital pseudoarthrosis of the tibia, congenital pseudoarthrosis of fibula is rarer. But unlike, again, congenital pseudoarthrosis of the tibia, it is less deforming, it is comparatively easier to treat, and it has a lesser morbidity when compared to the tibia. It often presents with a progressive ankle valgus deformity, more so when the distal fibula is affected. Till now, only 40 cases has been reported without involvement of the tibia simultaneously. And although various treatment modality has been discussed, but it's not well established yet. So there's a 5-year boy with a progressive ankle valgus deformity. He was initially treated as suspected trauma elsewhere, and he was applied plasters in spring. But again, after 10 months, the child presented with ankle valgus deformity and mild pain and prolonged walking on the middle aspect of the foot. So he also had a cafe outlet spot. His father has a family history of neurofibromatosis 1. He presented with left ankle valgus deformity, but the ankle range of motion was full. There is no other deformities like in spine. The X-rays showed pseudoarthrosis. Like in the X-ray, you can see there is a pseudoarthrosis in the distal third of the tibia. There is ankle valgus, and there is higher stationed fibula. So the fibula is stationed higher. You can see the talus is tilted laterally and shifted. This is the normal side. There is also a procurvatum deformity. If you see the station of the fibula, it is in grade 2 Malhotra grade. Clinically, you can appreciate ankle valgus deformity. There are several cafe outlet spots which are more than 5 mm. So what is the role of the fibula, and how whenever one side or one strut of the leg is absent, how the deformity happens? So in case of fibula, whenever there is discontinuity of the fibula, because of the anti-gravity muscles and posterolateral muscle, bulky muscles, and the weight transmissions, the talus starts to tilt laterally and shift laterally. The fibula goes up, and there is also secondary changes like there is wedging of the distal tibia epiphysis. And because of all these force, whenever the one strut of the couple is not working, then there is a progressive uh, deformity which happens in the tibia as well, which is similar to congenital pseudoarthrosis of tibia, where anterolateral angulation is seen. So this phenomenon of deformity has been published by me and Dr. Anil in JPO 2023. So looking at the problems of this case has a pseudoarthrosis. It's not a traumatic pseudoarthrosis, it's a congenital and associated with neurofibromatosis. So which whenever there is association with neurofibromatosis, there is likely that there is hematomatous tissue. So whenever reconstructed or whenever osteosynthesis is attempted, it might get resolved. Another problem is there is ankle valgus deformity, which is progressive. The age is 5 years, so the child physis is wide open, and there is high distal fibula station. So how to tackle each problem? So the strategy that we discussed were, so since there is high chance of resorption of the pseudoarthrosis whenever the bone grafting has been done, so we plan to excise the pseudoarthrosis. Then to correct the ankle valgus deformity, we choose to do the growth modulation as the physis is wide open, and there is a progressive deformity, so that we can do overcorrection instead of any osteotomy. And there is another problem of higher distal fibula station, so there is always chance of recurrence even after correction of the deformity. So our strategy was fusion of the distal tibia and fibula. Various other techniques has been tried, like along with the deformity correction, people have attempted to do the osteosynthesis of the fibula. The results are varied. Some had a resorption of the case, some had recurrence, some had well corrected deformity, which was with no recurrence. So we went to the literature and found the similar case reports, which was first published by Dr. Langenskiold in JVGS in 1967. So he applied the same. He applied the principles. So the procedure is named after Dr. Langenskiold. So what he did was he opened up the fibula from lateral side, and then excised the distal, the non-pseudoarthrotic segment of the distal third of the fibula. And instead of using the bone graft from the fibula, which is again a pathological tissue, he used the bone graft from the iliac crest with a strut, and then just around 1.5 to 2 centimeter above the distal fibular physis, he made a crest. He made a shelf which was inserted into the distal third of the tibia, well above the physis and well above the syndesmosis. So the plan was to fuse the distal tibia and fibula. As the growth rate of the tibia and fibula is similar, so the fusion won't affect the growth later on. The principle of similar growth was applied here. So we did the same procedure. We excised the pseudoarthrotic segment. We followed the plane of soft tissue and then raised till the normal bone bleeding was seen. So we excised both the proximal and distal. In en bloc excision was done, and then we entered through the same incision. We through the same approach, we reached the distal third of the tibia, and then we elevated the periosteum, got the harvested bone graft from the iliac crest, and just above the physis, around 2 centimeter above the distal fibular physis, we in the metaphysis region we applied the bone graft and inserted into the distal third of the tibia like a shelf, and additional bone grafts were kept so that the healthy bone graft won't get resolved later. And for the support of this fusion, we also had inserted distal syndesmotic screw, but well above the syndesmosis. And to correct the deformity in a so we applied medial distal tibia hemiepiphysiodesis with a screw for the temporary purpose. So in the result, in early post-op period, the biopsy showed, as expected, the tissue was consistent with the hematoma, which was likely to get, the bone graft was likely to get resolved if it was kept there. So we, once the bone graft showed integration, we allowed full weight bearing on the cast, and we found that at the 4 months follow-up, the graft had already fused with the tibia. So, and gradual improvement of the angulus valgus was noted. So this the lateral distal tibial angle, which is 73 degree, it was normalized by 1 year till 90 degree, and no resorption of the graft was seen. So at 16-month follow-up, the angle valgus was corrected till the normal values. There is no restriction of the joint movement, ankle movement, and there is no any pain or limitation of the activities. We kept the screw for additional 2 to 3 months, 3 months, so that there is a slight overcorrection, so that we can avoid recurrence of the ankle valgus, and you can appreciate there is complete fusion of the tibia and fibula, and there is no resorption of the graft. And then the wedging, even the wedging has been corrected. The distal tibia lateral aspect, the talar dome now appears parallel to the floor. So so we remove this graft, we remove this implant after the full correction was achieved. So this technique, looking back to the literature, so this congenital pseudoarthrosis of tibia, even it is rarer, but the deformity is less severe when compared to the tibia. Pseudoarthrosis are often associated in 60 to 90% cases. It is associated with the congenital pseudoarthrosis of tibia and neurofibromatosis 1. Kids can present at various ages. There are various case series by Cho et al., where the mean age of presentation was 3.9 years, and it is 7.6 years by Martus and Johnson. Deformity was also variable based on the gap. The more the gap, there was higher deformity. This was reported by Disdiviani. And the restoration of fibular continuity and distal tibial fusion was applied in various cases, in various series by Yang et al. And Cho et al. The Cho et al., he did both the strategy of distal excision of the pseudoarthrosis and also osteosynthesis of the fibula, and the results were variable. There are 2 cases of recurrence out of 13 cases. Similarly, Lambasi did the Langenskiold procedure, where he excised the fibula, and the valgus deformity was corrected in 7 cases with the fusion of the distal tibia and fibula. So looking at the literature in our case experience, so what we can conclude is, before making a treatment strategy for this case, you have to look at the age, what is the rapidity and severity of the progression of the deformity, what is the status of the distal fibula. Has it undergone, has it gone to the pseudoarthrosis, or is it just tapered? What is the state of the distal physis? If the case presents late, maybe after 11 years, there is less chance that we can get full correction of deformity by hemiepiphysiodesis. So considering these cases, to stabilize the ankle to prevent the recurrence, the distal tibia fibular fusion seems to be a good option, and has been tried by various authors. And there are various authors have also tried fibular osteosynthesis to prevent the recurrence of the deformity, but the results were variable. Some had resorption, some had non-resorption. So to correct the deformity based upon the age, the child is older age, after 11 or 12 years, the growth modulation might not work. So in those cases, malleolar varicization of the tibia should be done. And whenever there is enough growth remaining, the growth modulation can be done. So talking about the growth modulation in the distal tibia, both a plate or temporary hemiepiphysiodesis with this screw can be done. So the results are good, and there is less permanent deformity by the use of screw, as reported by Dr. Anil Agarwal. So the screw hemiepiphysiodesis seems to be a good option for these cases. So thank you for the.
Thank you, Dr. Nitish, for a simple solution for a difficult case, and age-old Langenskiold procedure, which has brought out an excellent outcome in this particular case.
Thank you, sir.
Now, my question is, how far you resect proximally? How do you decide that this much to be resected?
Yeah. First, we follow the soft discipline. Before going to the bone proper, we follow the
Yeah.
soft discipline.
So there will be fibrous in there, so fibrous tissue exercise. So till you reach the bone, or how do you decide
we
that
follow
this
the
endpoint?
first we see the soft discipline. The pseudoarthrotic segment hematomas tissue is slightly yellowish, and the texture is different when compared to the normal tissue. So we follow till the normal tissue comes, soft tissue. Then we go to the bone, and we drill the bone. The bone is bleeding properly, and there is no any tapering at that region. There is no sclerotic within the medullary canal. We excise till that segment. In distal segment, we had to do under excision, because if we go more distally, then we might reach the physis. So in distal region, we kept some portion of the metaphysis.
Okay. So you open up the medullary canal as well.
Yeah, we
The
open the
drilling.
medullary canal.
Right. Okay. Yeah. Over to
Uh,
Dr. Ankit. Yeah.
Great case, Dr. Nitish. I mean, I must congratulate you on the way you've managed it so well. And ankle valgus in such situations like you have presented in pseudoarthrosis fibula is akin to presentations that are seen with fibular hemimelia as well. So in early grades of fibular hemimelia, the presentations are very similar. And I have some experience of managing fibular hemimelias who have presented with this, with such a situation. So a couple of things that I want to ask you is, did the child have any limb length discrepancy as well, other than the
Yeah,
deformity?
at presentation, the child had limb discrepancy of 1 centimeter, and the
Okay.
discrepancy didn't increase after the hemiepiphysis
And
was
the age of
taken.
the child was at
5 years,
presentation was
5 years at presentation, 5 years,
okay.
5 years, 3 months might be at the surgery, and
Okay.
by 7 years, almost the last follow-up.
So if you can just hold this slide that you have, right now. The only thing that I, tend to slightly differ on in the way that you manage this, that the level of the fibula is slightly higher than what it normally should be. So on the X-ray on the left, the one in which the procedure has been done, you see that the tip of the fibula is at the same level as the tip of the medial malleus.
Yeah.
So what can happen, when you leave it at that level is the hind foot or the subtalar joint can, later on progress into valgus. So that can lead to sort of a recurrence. The only thing that I would differ is probably push down on my fibula slightly more down
Yeah,
so
yeah.
as to, in
This is not the
adults,
final. This is not the final follow-up. This one is the final follow-up. So
so
fibula
even in
is now
this,
down.
so
It's
even
in
in a final follow-up,
station
the
is
idea
one.
is
So station 0 and 1 is normal for the children.
the idea is that the talocrural angle will dictate the amount of fibula length that should be achieved. One. And in a child, the physis of the fibula should lie at the level of the dome of the talus. So those are the two ways that you can determine as to where the fibula should lie, because the fibular physis is not at the level of tibial physis. It has to be slightly more distal. I mean, great case, amazingly done. But that is one thing that you can slightly improve upon. The other thing is there is also cornal plane bowing or deformity. Do you think that is going to affect the outcome long term, or
No,
anything
no.
that can be done for that?
In children, the deformity in the sagittal plane, that is likely that gets remodeled in the
Sorry,
later.
right.
Yeah,
Okay, you feel that that will get remodeled.
yeah.
Okay, and there is literature to support that as well, I believe.
Literature to support that. And about this molecular grade of this distal fibular station, we've done a study, quite long series in Chachan hospital, to know the
Mhm.
normal station. So 0 and station 1, and that is up to the level of the distal epiphysis, is considered normal, because they have less chances of recurrence. This is a study. The study has been done based upon the fibular bone graft harvesting for various purposes.
Okay, great. I mean, very well done, and I think amazing result as well.
Thank you.
Congratulations.
Did you do a epiphyseal disease of the tibia by that screw? Which you have put?
Hemiepiphyseal, sir.
Hemiepiphyseal disease. Okay.
Hemiepiphyseal in the medial side.
Okay. Normally, at what age you should address this? Any particular age, or you just to?
No, we there are based on the classification. There is a dual classification which says whether there is progressive angle valgus or not, and whether the fibula is already gone into pseudoarthrosis. So already pseudoarthrosis, the deformity is progressive, and the child is having some discomfort. Then we should address, because there is no point waiting, because the secondary changes happens in distal tibia as well, and talus continues to shift laterally and tilts laterally. So it is going to affect later.
Yeah. And as Dr. Ankit was pointing out, uh, with this, hemiepiphyseal disease and this fusion, it will affect the length of that leg eventually, isn't it?
Yeah, the length,
That,
it's per se because of the pseudoarthrosis can be there, limb length discrepancy, but in children, if there is more than 3 centimeters, then we can do again epiphyseal to equalize the limb length later. if there is discrepancy.
On the contralateral side.
On the
Yeah, on the
unaffected side.
contralaterals. Yeah.
Contralateral side. Okay. So that you decide at what age?
That we decide later. During the development, if the limb
Second growth
discrepancy,
spurt,
yeah,
somewhere around that
if
time.
the discrepancy is more than 3 centimeter, so we don't, there is no point of waiting when there is limb discrepancy more than 3 centimeter. Before that, we can apply the Sue rays, and if it is progressive into successive visits, then we decide for limb equalization. That calculation is we do by the Pallet technique. There is a multiplier method. So what is the limb discrepancy that is going to happen at skeletal maturity? We calculate that. If it is well more than 5 centimeter, then we intervene even earlier.
I see. And after this epiphyseal disease and this, Langenskiold procedure, how long the patient remains non-weight bearing, or you allow weight bearing?
We allowed weight bearing after 4 weeks after this procedure, because the only thing that was for us was to integration of the bone graft. So we allowed after 4 weeks with the cast on. So
Okay.
in the next visit after again 4 weeks, once the bone graft was integrated, we removed the cast and allowed child to walk on. The only concern for is now whether there will be recurrence again or not. So that is a concern for us again.
So if there is a recurrence again, then what do you do?
So again, if the recurrence happens very late is, so then in that time we can do osteotomy. If it happens earlier, then again we can do hemiepiphyseal.
Excellent. Excellent case. Thank you for presenting.
Thank you very much.
Any other questions, Deepak?
No, sir. No. Nitish, you have any questions?
There's
a lot of
presenting the case. It's a very nice case. I just have one doubt. So did you check the position of the ankle while fixing the tibia and the fibula intraoperatively? So did you dorsiflex it completely?
Yeah, we did the dorsiflexion, but since the distal third of the fibula is already excised, I don't think it's going to make much changes, because the distal tibia fibula is not so well fused before at the time of the surgery. It is going to fuse few months later, so few weeks later. So, but even then, considering the principle, we did the dorsiflexion.
Okay.
So as to widen the
full range of motion.
Yeah.
Okay.
Okay.